Block simulation 25. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. What is the diagnosis and mechanism? A 30-year-old man has episodes of dark colored urine in the morning, fatigue, and recurrent venous thrombosis, including an unusual hepatic vein clot. Labs: hemolytic anemia, low haptoglobin, high LDH, with hemoglobinuria. Flow cytometry shows a deficiency of CD55 and CD59 on blood cells. Read the command, diagnosis, and mechanism. Morning hemoglobinuria, intravascular hemolysis, thrombosis, CD55, CD59 deficiency. Paroxysmal nocturnal hemoglobinuria. This is paroxysmal nocturnal hemoglobinuria, PNH. It is an ACQU-IRD clonal stem cell disorder caused by a somatic mutation in the PIGA gene, which is needed to make the GPI glycosylphosphatidylinositol ANSHOR that tethers certain proteins to the cell membrane. Two of those GPI-anchored proteins are CD55 and CD59, complement inhibitors that normally protect red cells from complement. Without them, the patient's complement system attacks the unprotected red cells, causing intravascular complement-mediated hemolysis, releasing free hemoglobin into the urine, hemoglobinuria, classically noted in the morning. The correct answer is B. The two hallmarks are the intravascular hemolysis with hemoglobinuria and a striking tendency to thrombosis, including unusual sites like the hepatic veins. Budd-Chiari syndrome, thought to result from complement-activated platelets and free hemoglobin scavenging nitric oxide. Diagnosis is by flow cytometry, showing absent CD55, CD59. Treatment is the complement inhibitor eculizum. Entry in quote: the acquired loss of GPI-anchored complement inhibitors causing intravascular hemolysis and thrombosis is paroxysmal nocturnal hemoglobinuria. According to Poiseuille's law, how does resistance depend on radius, and what is the clinical implication? A physiologist studies the determinants of blood flow and vascular resistance. He notes that small changes in vessel radius produce large changes in resistance and flow. Read the command, how resistance depends on radius, and the implication. R, 1, R. Small radius changes hugely affect resistance flow. According to Poiseuille's law, the resistance to flow through a vessel is I inversely proportional to the fourth power of the radius. I is proportional to 1 over R to the fourth, as well as directly proportional to viscosity and length. The fourth power relationship is the key. It means that even a small change in vessel radius produces a huge change in resistance. For example, having the radius increases resistance 16-fold 2 to the fourth, drastically reducing flow. The correct answer is A. The clinical implication is profound because resistance depends on R to the fourth power. The radius of the arterioles is the most powerful regulator of blood flow and blood pressure. This is why vasoconstriction and vasodilation, small radius changes, have such dramatic effects on perfusion and pressure, why the arterioles are the main site of resistance regulation, and why even modest atherosclerotic narrowing can severely limit flow. The inverse fourth power dependence on radius, making it the dominant determinant of resistance and flow, is the answer. Which molecule is the universal methyl donor, and how is it regenerated, involving folate and B12? A biochemistry student studies 1-carbon metabolism. A universal methyl donor is generated from methionine and is used in countless methylation reactions, DNA, neurotransmitters, etc. Read the command, universal methyl donor and regeneration. SAM, regenerated via homocysteine remethylation using folate and B12. The universal methyl donor is S-adenosylmethionine SAM, made from methionine and ATP. SAM donates its methyl group to countless reactions, methylating DNA, proteins, phospholipids, and neurotransmitters. After donating the methyl group, SAM becomes S-adenosyl homocysteine and then homocysteine. To regenerate methionine, homocysteine is remethylated. It receives a methyl group from methyl tetrahydrofolate from folate in a reaction catalyzed by methionine synthase, which requires vitamin B12 methylcobalamin as a cofactor. The correct answer is C. This links folate, B12, and homocysteine. When B12 or folate is deficient, homocysteine cannot be remethylated, so homocysteine accumulates, which is why both deficiencies raise homocysteine, a vascular risk factor. The methyl trap in B12 deficiency, folate gets stuck as methyl THF and cannot be used for DNA synthesis, explaining the megaloblastic anemia. SAM as a universal methyl donor regenerated by folate, and B12 dependent remethylation of homocysteine to methionine is the answer. Which set of structures masses is classically found in the anterior mediastinum? A 25-year-old man has a chest mass discovered incidentally. It is located in the anterior mediastinum. The radiologist lists the differential for an anterior mediastinal mass. Read the command. Which masses are in the anterior mediastinum? The 4 T's, thymoma, teratoma, thyroid, terrible lymphoma. The mediastinum is divided into compartments, each with a characteristic differential for masses. The anterior mediastinum in front of the heart is remembered by the 4 T's, thymoma associated with myasthenia gravis, teratoma and other germ cell tumors, thyroid masses, a retrosternal goiter extending down, and terrible, lymphoma Hodgkin and non-Hodgkin. These are the classic anterior mediastinal masses. The correct answer is C. Knowing the compartments helps localize disease. The middle mediastinum contains the heart, pericardium, great vessels, trachea, and main bronchi. Masses here include bronchogenic cysts, lymphadenopathy, and vascular abnormalities. The posterior mediastinum contains the esophagus, descending aorta, and sympathetic chain. Masses here are classically neurogenic tumors and esophageal lesions. The anterior mediastinal 4 T's, thymoma, teratoma, thyroid, and terrible lymphoma are the answer. What is the diagnosis, the key risk factor, and a first-line treatment? A 68-year-old thin postmenopausal woman with a long smoking history sustains a vertebral compression fracture after minimal trauma and has lost height. DEXA scan shows a T-score of 3.0 at the hip. Serum calcium, phosphate, and alkaline phosphate and alkaline phosphatase are all normal. Read the command, diagnosis, risk factor, treatment. Postmenopausal, fragility fracture, T-score C3.0, normal labs, osteoporosis, estrogen loss, bisphosphonates. This is osteoporosis, a reduction in bone mass, both mineral and matrix, with normal bone mineralization, leading to fragile bones prone to fracture with minimal trauma. Vertebral compression fractures, hip and wrist fractures. The diagnostic clue is the DEXA scan T-score of 2.5 or lower, here -3.0. And crucially, the serum calcium, phosphate, and alkaline phosphatase are all normal. Because the bone present is normally mineralized, there is just less of it. The correct answer is E. The key risk factor in this classification is postmenopausal, estrogen deficiency. Estrogen normally restrains osteoclast activity, so its loss accelerates bone resorption. Other risks are age, smoking, low body weight, and corticosteroid use. First-line treatment is bisphosphonates alendronate, which inhibit osteoclasts. The normal labs distinguish osteoporosis from osteomalacia, low vitamin D, abnormal mineralization, Paget disease high ALP, and hyperparathyroidism high calcium. The reduced bone mass with normal labs from estrogen loss, treated with bisphosphonates, is osteoporosis. What is the acid-base disturbance, the mechanism of her symptoms, and the management? A 22-year-old woman presents to the ED with acute anxiety, a panic attack, and rapid deep breathing. She has perioral and finger tingling and carpal pedal spasm, ABG, pH 752, PaCO2 26 mEHg, HCO3 23 mEHg. Read the command, disturbance mechanism management. anxiety, hyperventilation, high pH, low PaCO2, tingling spasm, acute respiratory alkalosis, low ionized calcium. This is an acute respiratory alkalosis. Anxiety-driven hyperventilation blows off CO2, so PaCO2 falls here 26, and because pH depends inversely on PaCO2, the pH rises 7.2. The bicarbonate is near normal because renal compensation takes days. This is acute. The symptoms, perioral and finger tingling, paresthesias, and chiropoptospasm, a form of tetany, are explained by the alkalosis affecting calcium. A higher pH increases the binding of calcium to albumin, lowering the ionized free calcium, which increases neuromuscular excitability. The correct answer is B. So alkalosis causes a functional hypocalcemia, low ionized calcium despite normal total calcium, producing the tingling, Chvostek and Trousseau signs, and carpal pedal spasm. Management is to correct the hyperventilation, reassurance, coaching slow breathing, and treating the underlying anxiety rebreathing into a bag is classically described but used cautiously. The acute respiratory alkalosis from hyperventilation, lowering ionized calcium to cause tetany, managed by slowing the breathing, is the answer. What is the drug class, mechanism, and a key advantage over older agents? A 30-year-old woman with major depressive disorder is started on a first-line antidepressant that increases synaptic serotonin. She is counseled it may take several weeks to work, and about initial GI upset and sexual side effects. Read the command, drug class, mechanism, advantage. First-line antidepressant raising serotonin, weeks to work, SSRI, safer in overdose than TCAs. This is an SSRI, a selective serotonin reuptake inhibitor. Fluoxetine, sertraline, citalopram, escitalopram, paroxetine. The mechanism is selective inhibition of the presynaptic serotonin transporter, blocking reuptake and INC-creating serotonin in the synapse. SSRIs are first line for major depression and many anxiety disorders because of their favorable side effect and safety profile. They take 4 to 6 weeks for full antidepressant effect, and common side effects are GI upset, sexual dysfunction, and initial anxiety insomnia. The correct answer is E. The key advantage over older antidepressants is safety, especially in overdose. SSRIs are far less dangerous than the tricyclic antidepressants, TCAs, which can cause fatal cardiac arrhythmias. Sodium channel blockade, wide QRS in overdose, an important consideration in depressed, potentially suicidal patients. The trade-offs, SSRIs can cause serotonin syndrome if combined with other serotonergic drugs, and abrupt discontinuation causes a withdrawal syndrome. The selective serotonin reuptake inhibition that is first line and safer in overdose than TCAs identifies the SSRI class. What is the diagnosis? A 65-year-old man presents with a rapidly enlarging lymph node mass and B symptoms. Biopsy shows sheets of large, atypical lymphoid cells that diffusely efface the node architecture. They are CD20 positive B cells with a high proliferation index. This is the most common aggressive non-Hodgkin lymphoma in adults and can arise de novo or transform from a lower grade lymphoma, e.g. CLL lymphoma, Richter transformation. Read the command, diagnosis. Rapidly enlarging node, large CD20 plus B cells diffusely effacing node, most common aggressive NHL, Richter transformation, diffuse large B cell lymphoma. This is diffuse large B cell lymphoma, DLBCL, the most common aggressive non-Hodgkin lymphoma in adults. It presents as a rapidly enlarging nodal or extranodal mass, often with B symptoms, fever, night sweats, weight loss. The biopsy shows sheets of large, atypical lymphoid cells that diffusely efface the normal node architecture, expressing the B cell marker CD20 with a high proliferation rate. It can arise de novo or by transformation from an indolent lymphoma, for example, Richter transformation of CLL or transformation of follicular lymphoma. The correct answer is D. The high yield points, DLBCL, is the most common aggressive NHL, is a large cell CD20 positive B cell lymphoma, and is the typical endpoint of Richter transformation from CLL and of transformed follicular lymphoma. Despite being aggressive, it is potentially curable with combination chemotherapy plus the anti-CD20 antibody rituximab-R. The rapidly enlarging mass of large CD20 positive B cells diffusely effacing the node, the most common aggressive NHL, is diffuse large B cell lymphoma. Which organism is responsible? A pregnant woman eats unpasteurized soft cheese and develops a febrile illness. Her neonate is born with sepsis and meningitis. The organism is a gram-positive rod that shows tumbling motility at room temperature, can grow at cold refrigerator temperatures, and spread cell to cell using ACTIN rockets, allowing it to evade antibodies. Read the command. Which organism? Unpasteurized cheese, pregnant neonate, gram-positive rod, tumbling motility, cold growth, actin rockets, Listeria monocytogenes. This is Listeria monocytogenes, a gram-positive rod that is a facultative intracellular pathogen. Its distinctive features: it shows tumbling malady. At room temperature, it can grow at cold refrigerated temperatures, so it contaminates unpasteurized dairy, deli meats, and refrigerated foods, and it spreads from cell to cell using ACTIN polymerization rockets, propelling itself through the cytoplasm into adjacent cells, without exiting into the extracellular space, which lets it evade antibodies. It is acquired from unpasteurized soft cheeses and other contaminated foods. The correct answer is C. The at-risk groups are key: pregnant women causing miscarriage, neonatal sepsis meningitis, granulomatosis infantiseptica, neonates, the elderly, and the immunocompromised. It is one of the top causes of neonatal and elderly meningitis. Because Listeria is intrinsically resistant to cephalosporins, treatment is ampicillin, which is why ampicillin is added to empiric meningitis regimens in pregnant and elderly patients. The cold-growing, tumbling, actin rocketing gram-positive rod from unpasteurized food affecting pregnant women and neonates is Listeria monocytogenes. Which statement about prolactin regulation is correct? A physiologist studies the regulation of prolactin secretion from the anterior pituitary. Unlike most pituitary hormones, prolactin is under tonic inhibition by the hypothalamus. Read the command. Which statement is correct? Prolactin, tonically inhibited by dopamine. Antagonists raise it. High prolactin suppresses NRH. Prolactin is unique among the anterior pituitary hormones in being under tonic inhibition. The hypothalamus continuously secretes dopamine, prolactin inhibiting factor, which travels down the pituitary stalk and inhibits prolactin release. So anything that reduces dopamine's effect raises prolactin. Dopamine antagonist drugs, antipsychotics, metoclopramide, and compression or damage to the pituitary stalk, interrupting dopamine delivery, both cause hyperprolactinemia. TRH also stimulates prolactin, which is why primary hypothyroidism, high TRH, can raise it. The correct answer is C. The downstream effect of high prolactin is the high yield point. Prolactin suppresses NRH from the hypothalamus, lowering LH and FSH, which causes amenorrhea, infertility, low libido, and galactorrhea. This is the physiologic basis of lactational amenorrhea and of the symptoms of a prolactinoma. It also explains why dopamine agonists, bromocriptine, cabergoline, treat hyperprolactinemia. They restore dopamine's inhibition. The tonic dopamine inhibition of prolactin, with antagonists raising it and high prolactin suppressing NRH, is the correct statement. What is the diagnosis? A 45-year-old man with chronic hepatitis B presents with fever, weight loss, abdominal pain, hypertension, a mononeuritis, multiplex foot drop, and skin nodules. Biopsy of a medium-sized artery shows transmural inflammation with fibrinoid necrosis, and angiography shows microaneurysm's rosary bead appearance. The lungs are spared. P-ANCI, ACE-B-AID. Appearance B. A lungs are spared. P-ANCRC, ANCRC, AC-NC are negative. Read the command. Diagnosis: HBV, medium vessel vasculitis, microaneurysms, lung spare, ANCA negative, polyarteritis nodosa. This is polyarteritis nodosa, PAN, a systemic vasculitis of median-sized arteries. It is associated with chronic hepatitis B infection, immune complex mediated. It causes transmural inflammation with fibrinoid necrosis of the vessel wall, leading to weakening and the formation of microaneurysms, the classic rosary bead or string of beads appearance on angiography. Clinically, it produces fever, weight loss, abdominal pain, mesenteric involvement, HY hypertension, renal artery involvement, meningitis multiplex like a foot drop, and skin lesions. The correct answer is B. Two discriminating features are high yield. PAN classically spares the lungs, distinguishing it from the ANCA-associated vasculitides like granulomatosis with polyangiitis, which prominently involve the lungs, and it is ANCA negative. The lesions are also of different ages, occurring in a segmental rosary bead pattern. Treatment is corticosteroids with cyclophosphamide if severe, plus antiviral therapy if HBV associated. The HBV-associated, lung-sparing, ANCA negative medium vessel vasculitis with microaneurysms is polyarteritis nodosa. What is this finding and the pathway of the pupillary light reflex? A patient has a swinging flashlight test. When light is shown in the right eye, BOT pupils constrict normally. When the light is swung to the left eye, BOT pupils paradoxically dilate. The left optic nerve was damaged by optic neuritis. Read the command, the finding, and pupillary reflex pathway. Swinging flashlight, dilation on affected side, optic neuritis, relative afferent pupillary defect, Marcus Gunn, afferent CN2, afferent CN3. This finding is a relative afferent pupillary defect, RAPRAPT, or Marcus Gunn pupil. To understand it, know the pupillary light reflex pathway. The afferent sensory limb is cranial nerve 2, the optic nerve, carrying the light signal to the brain. The signal then drives both Edinger, Westphal nuclei. The efferent motor limb is cranial nerve 3. The oculomotor nerves, parasympathetic fibers, constricting both pupils, the consensual response. When the left optic nerve afferent limb is damaged, light shown in that eye is transmitted po-orally, so the brain perceives less light and both pupils paradoxically dilate when the light swings to the affected eye. The correct answer is A. The swinging flashlight test isolates the afferent defect. The consensual constriction is normal when the good eye is lit, but when the light swings to the eye with the damaged optic nerve, the reduced afferent input causes both pupils to dilate. The pupillary reflex pathway, afferent optic nerve, CN2, afferent oculomotor parasympathetics, CN3, is the framework. A damaged optic nerve causing a relative afferent pupillary defect, Marcus Gunn pupil, is the finding. What is the diagnosis and what is the minimum duration and symptom requirement? A 35-year-old woman reports 3 weeks of depressed mood, loss of interest in activities, anhedonia, poor sleep, low energy, poor concentration, decreased appetite with weight loss, feelings of worthlessness, and passive thoughts of death. These symptoms are present nearly every day and impair her functioning. Read the command, diagnosis, duration, requirement. Depressed mood, anhedonia, plus neurovegetative symptoms, 3 weeks, major depressive disorder, TIF-T symptoms, T 2 weeks. This is major depressive disorder. The diagnosis requires at least FI5 of 9 symptoms present for at least TW weeks nearly every day, causing functional impairment, and at least one of the 5 must be either depressed mood or anhedonia, loss of intrastate pleasure. The symptoms are captured by the mnemonic SIG ECAPS: sleep changes, loss of interest, anhedonia, guilt worthlessness, low energy, poor concentration, appetite weight changes, psychomotor changes, and suicidal ideation, plus depressed mood. This patient meets the criteria with more than 5 symptoms over 3 weeks. The correct answer is E. The key thresholds to memorize: at least 5 symptoms for at least 2 weeks, with at least one core symptom, depressed mood or anhedonia, causing distress or impairment. Contrast with persistent depressive disorder, dysthymia, which is milder but lasts at least 2 years, and with normal grief or adjustment disorder. First-line treatment is an SSRI plus psychotherapy. The 5 or more depressive symptoms, including depressed mood or anhedonia for at least 2 weeks with impairment, defines major depressive disorder. Which transport system enzyme is deficient and what accumulates? A patient has muscle pain, weakness, and myoglobinuria after prolonged exercise or fasting with a deficiency in fatty acid oxidation. The defect is in the enzyme that shuttles long-chain fatty acids, IN to the mitochondria, the rate-limiting step of beta oxidation. Read the command, which transport enzyme is deficient and what accumulates? Carnitine shuttle, CPT-HIII, transports long-chain fatty acids into mitochondria. The deficient system is the carnitine shuttle, mediated by carnitine palmitoyltransferase, CPTI-ND2, and the carnitine acylcarnitine translocase. Long-chain fatty acids cannot cross the inner mitochondrial membrane on their own. They must be conjugated to carnitine by CPTI, transported in, and then released by CPTI to undergo beta oxidation. This shuttle is the rate-limiting step of fatty acid oxidation. When it is deficient, E-deoxymyelolysis with myoglobinuria, CPT-diatic hypoglycemia, so during prolonged exercise for energy, so during prolonged exercise or fasting. When the body depends on fat, patients develop muscle weakness, pain, and rhabdomyolysis with myoglobinuria, plus hypoketotic hypoglycemia. The correct answer is A. What accumulates as long-chain fatty acyl groups as acylcarnitines and toxic intermediates, with an inability to make ketones during fasting, hypoketotic hypoglycemia, like MCAD-D deficiency, but a transport rather than enzymatic block of beta oxidation. Carnitine deficiency itself, primary or secondary to certain conditions, impairs the same shuttle. The carnitine shuttle, CPT, defect, preventing long-chain fatty acid entry into mitochondria, causing muscle symptoms and hypoketotic hypoglycemia, is the answer. Which statement about breast cancer receptor subtypes and treatment is correct? A 52-year-old woman has an invasive ductal carcinoma of the breast. Pathology reports the receptor status to guide treatment. Read the command, which receptor treatment statement is correct? ER/PR plus double hormonal therapy, HER2 plus double trastuzumab, triple negative 5 chemo, worst prognosis. Breast cancer treatment is guided by 3 receptors. ER/PR, positive. Hormone receptor positive tumors are driven by estrogen, so they respond to hormonal therapy. Tamoxifen, a selective estrogen receptor modulator or aromatase inhibitors in postmenopausal women. HER2, positive tumors overexpress the HER2 new growth receptor and respond to trastuzumab, Herceptin, an anti-HER2 monoclonal antibody with cardiotoxicity as a key side effect. Triple negative breast cancer, ER negative, PR negative, and HER2 negative, lacks all 3 targets, so it has no targeted therapy, is treated primarily with chemotherapy, and carries a worse prognosis, and is more common in BRCA1 carriers and younger African American women. The correct answer is E. So, the receptor profile dictates therapy, hormone receptor positive disease gets endocrine therapy, HER2 positive disease gets anti-HER2 antibodies, and triple negative disease, lacking targets, relies on chemotherapy, and has the poorest prognosis. This is why receptor testing ER/PR HER2 is routine on every breast cancer. The ER/PR HER2 is routine on every breast cancer. The ER/PR hormonal, HER2 trastuzumab, and triple negative chemotherapy relationships are the correct statement. What is the key difference and its physiologic purpose? A physiologist compares the response of pulmonary versus systemic blood vessels to local hypoxia, low oxygen. Read the command, key difference and purpose. Pulmonary vessels constrict with hypoxia, divert from poorly ventilated alveoli. Systemic vessels dilate, increase flow to hypoxic tissue. The key difference is that pulmonary and systemic vessels respond to hypoxia in opposite ways. In the pulmonary circulation, alveolar hypoxia causes VA constriction, hypoxic pulmonary vasoconstriction. Its purpose is clever. It diverts blood away from poorly ventilated low oxygen alveoli toward better ventilated alveoli, optimizing ventilated alveoli, optimizing ventilated alveoli, optimizing ventilated alveoli, optimizing ventilation perfusion matching to maximize oxygenation. In the SY systemic circulation, hypoxia causes vasodilation. Local low oxygen relaxes the arterioles to INT, blood flow and oxygen delivery to the metabolically active or hypoxic tissue. The correct answer is D. The logic makes physiologic sense from each system's job. The lung's goal is to match perfusion to ventilation, so it shunts blood toward well-oxygenated regions by constricting vessels in hypoxic ones. The systemic tissue's goal is to receive enough oxygen, so they dilate to pull in more flow when oxygen is low. The downside of pulmonary vasoconstriction, chronic, global hypoxia, chronic lung disease, altitude, constricts the whole pulmonary bed, raising pulmonary artery pressure and causing pulmonary hypertension and cor pulmonare. The opposite hypoxic responses, pulmonary constriction versus systemic dilation, are the answer. What is this skin finding? What does it indicate? And what is the concerning association when it appears suddenly? A 55-year-old obese man with type 2 diabetes, or, in another case, a patient with new onset gastric cancer develops symmetric, velvety, hyperpigmented, thickened plaques in the body folds, the axillae, neck, and groin. Read the command, what the finding is, indicates, and the concerning association. Velvety hyperpigmented plaques and folds, acanthosis nigricans, insulin resistance, sudden onset, visceral malignancy, gastric. This is acanthosis nigricans, symmetric, velvety, hyperpigmented, thickened plaques in the flexural areas, axillae, posterior neck, groin. Most commonly, it is a marker of insulin resistance. It is strongly associated with obesity, type 2 diabetes, and conditions like PCOS. High insulin levels stimulate keratinocyte and fibroblast growth. So, it is a useful clinical sign of metabolic syndrome and hyperinsulinemia. The correct answer is D. The concerning association is the high yield twist, when acanthosis nigricans appears suddenly, rapidly, and extensively. Especially in a non-obese or older patient, it can be a paraneoplastic sign of an underlying visceral malignancy, classically gastric adenocarcinoma, and other GI cancers. This warrants a malignancy workup. A related sign, the sudden eruption of mini-seborrhea keratosis, is the lesser Trellat sign, also linked to GI cancer. The velvety hyperpigmented flexural plaques indicating insulin resistance, or, if sudden, visceral malignancy, are acanthosis nigricans. Which drug is preferred in the first trimester? And what are the mechanisms and key toxicities of the two antithyroid drugs? A pregnant woman in the first trimester is diagnosed with hyperthyroidism, Graves' disease, and requires an antithyroid drug. Read the command, which drug in first trimester and mechanisms, toxicities. PTU first trimester, methimazole, teratogenic, both block peroxidase. PTU also blocks T4/SAST3, PTU hepatotoxic. The two antithyroid drugs are propylfluorouracil, PTU, and methimazole. Both inhibit thyroid peroxidase, the enzyme that organophores iodine and couples iodotyrosines, blocking new thyroid hormone synthesis. PTU has an additional action. It also inhibits the peripheral conversion of T4 to the more active T3,5-dihydinase, making it useful in thyroid storm. The choice in pregnancy by trimester is the key point. PTU is preferred in the first trimester because methimazole is teratogenic, causing aplasia cutis and other defects. Methimazole is then preferred in the second and third trimesters because PTU risks hepatotoxicity. The correct answer is B. The high-yield pairings, methimazole is teratogenic aplasia cutis, so it is avoided in the first trimester. Use PTU then. PTU carries a risk of hepatotoxicity and is generally avoided later, switching to methimazole after the first trimester. Both can rarely cause a granulocytosis. The shared peroxidase inhibition, PTU's extra block on peripheral conversion, and the first trimester preference for PTU because methimazole is teratogenic are the answer. Which group of organisms causes this, and how is Tinea versicolor different? A wrestler develops itchy, scaly, ring-shaped skin lesions with central clearing and a raised advancing border on his trunk. Tinea corporis. A KOH preparation of a skin scraping shows branching, septate, -E. Read the command. Which organisms cause tinea and how versicolor differs? Dermatophytes, Trichophyton microsporum, Epidermophyton, septate hyphae, Tinea versicolor, Malassezia spaghetti, and meatballs. Tinea ringworm is caused by dermatophytes, a group of 3 fungal genera, Trichophyton, Microsporum, and Epidermophyton. They infect keratinized tissue, skin, hair, nails, producing itchy, scaly, ring-shaped, annular lesions with central clearing and a raised advancing border. A KOH preparation of a skin scraping dissolves the keratin and reveals the branching, scraping dissolves the keratin and reveals the branching, scraping dissolves the keratin and reveals the branching, septate -E. The lesions are named by location: Tinea corporis, body; Tinea pedis, athlete's foot; Tinea cruris, groin jock itch; Tinea capitis, scalp; and onychomycosis, nails. The correct answer is A. The contrast with Tinea versicolor is the key distinction. Despite the Tinea name, it is not caused by dermatophytes, but by Malassezia pityrosporum, a yeast that causes hypo, or hyperpigmented patches, classically on the trunk, with a characteristic spaghetti and meatballs appearance on KOH for short hyphae and round yeast. Dermatophyte tinea is treated with topical or oral antifungals like terbinafine or azoles. The septate hyphae dermatophytes causing ringworm, distinct from Malassezia causing Tinea versicolor, are the answer. What is this complication, the mechanism, and the typical target organs? A patient receives a bone marrow hematopoietic stem cell transplant. A few weeks later, she develops a diffuse skin rash, profuse diarrhea, and abnormal liver function tests, jaundice. The donor's immunocompetent T cells are attacking the recipient's tissues. Read the command, complication, mechanism, target organs. Bone marrow transplant, donor T cells attacking host, rash, diarrhea, jaundice. Graft versus host, disease, skin, GI, liver. This is graft versus host disease, GVHD. It occurs particularly after bone marrow hematopoietic stem cell transplantation, where the graft contains immunocompetent donor TCELs. The mechanism is the reverse of normal transplant rejection. Instead of the host attacking the graft, the donor's T cells recognize the recipient's tissues as foreign and attack them. The classic target organs are 3. The scium are maculopapular often the first sign, the GI tract profuse, sometimes bloody diarrhea, and the liver are abnormal LFTs and jaundice. The correct answer is D. The direction is the key concept. GVHD is graft versus host, donor immune cells attacking the recipient. The opposite of host versus graft, R ejection recipient attacking the donor organ. It is a major complication of allogeneic bone marrow transplant and is prevented, treated with immunosuppression and by HLA matching. Interestingly, a degree of graft versus tumor effect can be beneficial against leukemia. The donor T cells attacking the recipient's skin, gut, and liver after a marrow transplant is graft versus host disease. Block 25 is done. 500 questions simulated. Let's review the 5 biggest traps from this block. Trap 1. Paroxysmal nocturnal hemoglobinuria comes from loss of the GPI-anchored complement inhibitors, CD55 and CD59, causing intravascular hemolysis and thrombosis. Diagnosed by flow cytometry, treat with eculizumab. Trap 2. Resistance is inversely proportional to the fourth power of the radius, so tiny changes in vessel radius cause huge changes in resistance and flow, making the arterioles the master regulator of blood pressure. Trap 3. Polyarteritis nodosa is a medium vessel vasculitis associated with hepatitis B that classically spares the lungs and is ANCA negative, distinguishing it from the lung-involving ANCA vasculitis. Trap 4. Prolactin is unique in being under-tonic dopamine inhibition. Dopamine antagonists or stool compression raise it, and high prolactin suppresses ENRH, causing amenorrhea. Dopamine agonists treat it. Trap 5. Acanthosis nigricans usually signals insulin resistance, but a sudden, extensive eruption can be a paraneoplastic sign of visceral malignancy, classically gastric adenocarcinoma. 500 questions, 25 blocks. Train process, not memorization. StepLogic, learn how to think, not memorize.